Welcome, ladies and gentlemen. Today we are going to look at urinary tract infections. In our outline, we are going to look at the definition, the etiology. We are going to look at the classification, and then we are also going to look at the clinical features. How can you diagnose someone who has a urinary tract infection? We are also going to look at the treatment, and then we shall look at the complications of UTI. So, in the definition, what is a UTI? And this is a microbial infection that affects any part of the urinary tract system, which includes the kidneys, the ureters, the bladder, and then the urethra. So normally the urinary tract is sterile due to the fact that the bacteria moves upwards and regularly washed out by urination. So the process of urinating tries to wash out any organism that might have been acquired and is trying to infect that system. So the bladder is capable of clearing these organisms by 2 to 3 days from the day of introduction. And the mechanism include the elimination of the bacteria by voiding or urinating, then the antimicrobial properties of the urine itself and its contents, the intrinsic mucosal bladder defense mechanisms that also exist, and then the acidic vaginal environment in females, and then the prostatic secretions in male. These are the major defense mechanisms that you have for prevention of UTI. Therefore, for UTI to occur, one of those mechanisms have been distorted in one way or the other. In the pathogenesis, you should know that the infections ascends through the urethra and then to the bladder. So that's one route. When it ascends, it can go further to the ureters, then the renal calyx. This is inside the kidney. So mostly we have E. coli being the most common or the leading cause of UTI. Then the second cause is or mostly identified organism is Staphylococcus saprophyticus. Yes, this is the second most common leading cause. Then you have Klebsiella coming in, and then protease. Yes. And then other organisms are there like the nosocomial bacteria. Then you have the Serratia marcescens, then Enterococcus species, Pseudomonas aeruginosa, they're also there. Then you have Enterobacter species also being there, and Ureaplasma ureaticum also being there. So other pathogens include viruses. Yes, you have mostly in immune compromised individuals. You have adenovirus, cytomegalovirus, and then also herpes simplex virus. Yes, you have herpes simplex virus. Simplex virus, yes. And then yeast, mostly candidiasis. So majorly you have those three: the bacteria, the viruses, and the fungi. We have some acronym here that can help us. That is SICPP. The S for Staph, Saprophyticus, the E for E. coli, Enterobacter, Klebsiella. You have the P for Protease, another P for Pseudomonas aeruginosa. Yes. So there are some factors that can predispose you to getting UTI, or we call them the host dependent factors. So most of them are related to either functional or structural abnormalities of the urinary tract system. This prevent bladder emptying and result into urine stasis. And when you have urine stasis, this will enable the growth and multiplication of these bacteria. So one of them is BPH. Yeah. Then you have congenital malformations causing vesico-uteral reflux. So you have these congenital malformations that can cause the urine to move backwards from the bladder to the ureters and hence can reach the kidney. Then you also have any diverticulum or outpocketing within the bladder. So some urine will collect inside there. There will be incomplete emptying. Then you also have neurogenic bladder that can also predispose someone. And then you also have urinary tract caliculi, or we have stones. So they will also prevent the complete emptying of the bladder. More, we have the host dependent factors that have been continued to be discussed, and this include sex. Mostly in females, you see that the urethra is a little shorter, and then these all organs are a little close to each other around the vulva, so they are predisposed to acquiring this UTI. That's why urinary tract infection are a little common in ladies compared to gentlemen. And then you have male individuals who are not circumcised being also at increased risk of getting urinary tract infection. Then you have pregnancy, hormonal changes they bring about uh, urinary bladder stasis, and then increase in vesico-uteral reflux. So because of the gravid uterus, there is compression of the bladder and incomplete emptying, and also there is increase in the pressure inside the bladder, hence allowing the reflex or backward movement of urine towards the kidney through the ureters, increasing the risk of getting UTI. Then postmenopausal women, because of low levels of estrogen, you have decreased levels of lactobacilli, hence you have the pH around the genitalia a little going to alkaline, which favors the growth of E. coli. Then you also have chronic constipation in children. Because of the chronic constipation, this may also compress the bladder, hence predisposing to UTI. Prior conditions like previous UTIs, history of kidney injury, and then you have immunosuppression, and then there are organisms that mostly affect individuals that are immune suppressed, like DM, HIV. So those individuals can easily be affected by Pseudomonas, causing a UTI. Then also increased use of antibiotics. They tend to lower the normal flora. So there is imbalance between the normal microbiome, and then this will predispose an individual to getting UTI. Also, you also have other conditions like, of course, this is very famous. The act of sexual intercourse itself can predispose you to getting urinary tract infections. Then you also have things like honeymoon cystitis, yes, due to increased sexual activity during that period. Then you also have use of diaphragm and spermicides. And then you also have catheter-associated urinary tract infection because of indwelling catheters. So the most common cause of nosocomial urinary tract infection is that catheter-associated urinary tract infection. So we have looked at this pathogenesis, but to throw more light on it, you have intraito colonization. Within the introitus, bacteria colonizes that place. So what will happen next is the urethral colonization. So from the introitus, then it's now going to the urethra. So you see that this is now moving into the urinary tract infection. Then now you have it ascending to the bladder. That's what we are calling bladder inoculation. And this will result to inflammation of the bladder. In case the organisms continue to ascend up, you're going to have the inflammation of the ureters and the kidneys, pyelonephritis. And then the process can continue. Don't forget that from the introduction in the introitus was done by either sexual activity or the gut flora can colonize that area due to the various factors we have seen, and among them is decreased estrogen levels. So we have two routes of entry mostly. We have the hematogenous spread and then the ascending spread. This route of ascending, we have already seen it. That is basically what has been explained in our pathology. And then the hematogenous route, it can be through seeding of the kidney during the course of bacteremia. So the major causes of hematogenous spread include Staph aureus, Salmonella species, Pseudomonas aeruginosa, and Candida species. And then let's classify UTIs. The various ways of classifying UTIs. One, you can base on presence or absence of symptoms. That is by clinical presentation. So you'll notice that some people will be asymptomatic and it will be a finding on routine examinations. Then others are going to have symptoms and we shall diagnose using urinalysis. That is the presence of symptoms and bacteremia and also pus cells. Then by location, you can have lower UTI or upper urinary tract infection. So generally here in the lower infection, it's affecting the bladder mostly and then the urethra. That's why you are having cystitis for bladder inflammation and urethritis for inflammation of the urethra. And then for the upper, this is mostly the kidneys and the ureters. So that's why you're having what we call pyelonephritis. The famous feature that you'll find pyelonephritis will be, we shall see what we call lower or lumbar tenderness. So that is by location. We can also classify by source. It can either be community acquired or a hospital associated UTI. And in hospital associated, that's where we are seeing things like catheter associated UTI. It can also occur secondary to urinary tract instrumentation. Maybe there was some procedure that was being done around that system and there was inoculation of the bacteria. Then we can also see where the recurrent UTIs. We have come across various cases of recurrent UTI, but then how would you say that? How would you know that this UTI is recurrent? So we classify it to be recurrent if you're having more than or equal to 3 episodes of symptoms that have also been proven by culture to have been caused by UTI in a year. That is 3 or more episodes of symptoms proven by culture in 1 year, or you're just having 2 or more episodes proven by culture in 6 months. So 3 episodes proven by culture to be a UTI in 1 year, or you can have 2 or more episodes proven by culture to be a UTI in 6 months. Then you can also classify based on severity. You can have either uncomplicated UTI or complicated UTI or urosepsis. So uncomplicated UTI, this is UTI in normally healthy individuals, that is the non-pregnant, premenopausal, any lady who has not reached menopause, and then also for uncomplicated UTI, there is nothing like treatment failure. So, but complicated UTI, here, if you are having the factors I'm listing below with failed treatment, so you have male sex, pregnancy. Actually, in male sex, the fact that a man has a UTI, that qualifies it to be complicated. Then postmenopausal, children with atypical pediatric UTI, significant anatomical functional abnormalities. So in case a UTI is an individual that has any functional or anatomical abnormalities, for example, we talked about diverticulum of the bladder, then immune suppression. So anyone who has a UTI and they are in that immune suppressive state, that is complicated UTI. Metabolic disorders like DM, infections associated with recent instrumentation like cystoscopy. Yeah, the device, you placed a scope and was used to visualize the bladder, then indwelling catheters, then drainage devices. And then for urosepsis, the UTI associated with dysregulated immune response that can potentially lead to life-threatening organ dysfunction. All right, let's look at the clinical features. We have irritative lower UTI tract, lower UTI symptoms. You have frequency, multiple episodes of urination in a day. You have urgency. So urgency, you have uncontrollable desire to urinate. And then dysuria, this is painful urination. You may or may not have hematuria, and then in some individuals, mostly the elderly, you can have suprapubic tenderness as the only presenting complaint. And then for pyelonephritis, you can have symptoms of the UTI that we have seen. Then you add fever, the frank pain, and then costal vertebral angle tenderness. We have looked at this. And then malaise, nausea, and vomiting. Yes. When you look at features of UTI in pyelonephritis, they are a little severe because you're having fever, frank pain, malaise, so you're having generalized symptoms. So generally, UTI with systemic symptoms is a complicated form of urinary tract infection, whereas UTI without systemic symptoms is uncomplicated. So additional features can be in males, pain in sorry about that. Pain in the perineal area or the prostatic area, and then also in old adults or elderly, they can present with delirium or acute onset confusion without any associated or any cause of the confusion. You have to query urinary tract infection. So those are the features. This slide tries to explain more about the features. Let's go and diagnose. So laboratory studies. One, urinalysis. Indications, the best initial test for all patients. The best initial. So baseline order for urinalysis. The procedure, they can do visualization, that is macroscopy, That's when you'll find things like turbid urine. Then they can do chemistry, that is dipstick. Then they can also do microscopic examination of the urine. So the specimen collection, the most important thing to note here is you need midstream sample. Clean, catch, midstream sample. So you tell someone to go, when they start urinating the 5 mils, they don't catch. Then midway they stop, they catch 10 mils in the middle, 5-10 mils. That is what is collected. Then after obtaining the sample, you can continue urinating. We need midstream. Then in case that's not possible and you're fearing that there may be some contamination, you can do straight catheterization. So here what you do, if in case someone has a catheter already, you remove that catheter, you place a new catheter, urinary catheter. So, and you don't obtain the sample from the urine bag. Immediately on placing the catheter, the first sample that will flow, you don't collect it. You collect midstream. So in both cases, you are only obtaining midstream urine, even from the catheter or not in the catheter. And I advise these individuals to swipe, then to swipe the area clean before obtaining the urine, and then also in case they are men that are uncircumcised, they are advised to retract the foreskin to prevent contamination of the sample. That's such that you can get accurate results. So typically, the findings on urinalysis of urinary tract infection include pyuria, that is the presence of white blood cells in urine. So here we are, detecting positive leukocyte esterase, an enzyme which is produced by white blood cells. Then on top of pyuria, we also detect bacteremia. So that is the presence of bacteria in the urine, and the positive urine nitrates is what we look for. So it indicates that there is a conversion of nitrites to nitrates by bacteria, mostly E. coli. Then you can also do the direct visualization of gram stain. So the major thing you should pick from the diagnosis is you need presence of symptoms, signs and symptoms. Then on top of that, you add presence of white blood cells. And then the other one, the presence of bacteria. Those are two. So the last thing that we are going to find is the pH. So what is the normal pH of urine? The normal pH of urine is 5.5 to 8. But in presence of bacteria like the protease, Klebsiella, Staphylococcus, what they do is they convert the nitrates that are in urine into ammonia, hence increasing the pH of urine to, to towards the alkaline. So if it's beyond 8, you are sure that you have UTI with the other findings. So if there are some squamous epithelial cells, that is a sign of contamination. So that is our urine dipstick. So you'll use this. These sticks here, they are always present inside this container. So you dip them in a sample of urine and then you compare with the various color changes. They can help us to check for the nitrates and most of what we have talked about. So you can also obtain culture of urine, And there are cases where urine culture is indicated. One, suspicion for complicated UTI, and then suspicion of pyelonephritis or urosepsis, and then suspicion of uncomplicated cystitis with either of the following: recurrent history of UTI, equivocal urinalysis, and atypical symptoms. So you are suspecting uncomplicated inflammation of the bladder with those features there. Then concern for multi-resistant pathogens in case the recurrent UTI and you think it is resistant to the antibiotics. Then follow-up culture for tests of cure. You can also do a follow-up culture for tests of cure in case non-resolving symptoms despite treatment, anatomical function abnormalities, and then also continued pathogenic findings on UTI. So how do you interpret your culture? Culture is considered to be positive when one significant bacteremia defined by more than we need 1,000. So we need 1,000 culture forming units per mil if they are obtained in that clean catch specimen. And then also we also need any organisms in the specimen obtained by suprapubic aspiration. So that is how you interpret your culture. If you have significant bacteremia, yes, that is more than 10,000. Yes, 10. Sorry, we are saying that for you to interpret your culture and sensitivity results, in case you find any organism in suprapubic aspiration, because this is a most safest method, but it's invasive for obtaining the sample. If you find an organism, that culture is positive. And then if you find 100,000 culture forming units on clean catch urine, that is considered positive culture. You can also do imaging. This is rarely done, but there are some cases whereby you are indicated or required to do imaging. In case of suspected urinary tract obstruction, severe illness, you can do it to exclude other causes. Then early recurrence of UTI within 2 weeks of appropriate treatment. Then persistent bacteremia despite treatment, recurrent complicated UTI, and then men with febrile UTI. There are also other modalities that can be used. On top of ultrasound, you can also do CT scan. So we have CT scan of the abdomen and pelvis with or without IV contrast. Then you have ultrasound of the bladder and then a kidney, the KUB ultrasound. Additional modalities may include MRI, abdomen, pelvis. Then you also have what we call voiding cystourethrogram can be done, or cystourethropy, and then retrograde cystography. This all can help us to visualize the anatomy of the urinary tract system. So how would you manage UTIs? So one, we have general principles that we use in management. One, we have antibiotic treatment. It's recommended for all patients with symptomatic UTI. And the optimal therapy depends on the disease severity, the local resistance patterns, patient characteristics, e.g., allergies, and then the initial treatment is with an empirical regimen which is maintained for uncomplicated cystitis. In clear or complicated cases, the regimen may subsequently be adjusted based on the sample. You can also consider supportive therapy, e.g., analgesia can be given for the pain. Okay, let's go to the treatment itself. For uncomplicated UTI, this condition can be managed in outpatient department, no need of admission in most cases because it's uncomplicated. The treatment duration depends on the chosen antibiotic regimen, and symptom relief can be expected to occur after an average of 2 to 3 days. Persistent symptoms despite antibiotic therapy suggest complicated UTI. Hence, you need to change the therapy to the second line or appropriate antibiotic therapy. So the first line can be nitrofurantoin. Nitrofurantoin, it's good, it is bacteriostatic. And then you can also give trimethoprim, sulfur, methoxyl, can be, or what we call septrin, can also be given, or phosphomycin, single dose, that is 3 grams per hour. So the second line, you can give an aminopenicillin or penicillins with beta-lactam inhibitors, that is amoxiclav can be given. You can also give cephalosporins like ceftriaxone. Alternatively, you can have the second line, that is fluoroquinolones like ciprofloxacin for 3 days in patients with previous infection with bacteria resistant to other medication. So for urethritis, inflammation of the urethra, you can in sexually active individuals, you can give IM ceftriaxone 250 milligrams plus either azithromycin 1 gram OD or doxycycline 100 milligrams BID for BD, that is BD for 7 days. For cystitis, the first line is nitrofurantoin 100 milligrams per hour BD for 5 days or septrin. We have already seen this. So for complicated cases, we have seen that we should give mostly fluoroquinolones. These are the best, that is ciprofloxacin can be given. In addition to antibiotic therapy, complicating factors, e.g. obstruction, should be treated if possible. So for men with UTI, refer to urologists for specific investigations. In case there is treatment failure, recurrent UTIs, hematuria, voiding difficulties, or suspected acute bacterial prostatitis, that is inflammation of the prostate gland. Yes, hospitalization and initial intravenous treatment may be necessary in the following cases: severe symptomatic features that are severe, like we have said, e.g., signs of shock. You can also give an initial IV treatment to those individuals that are not tolerating oral treatment. They're having nausea, they're having vomiting. Then also those that are having immunocompression and heart failure, you can give them rescue IV dosage before you go to the oral therapy. Yes. So let's look at management of complicating factors. Like you have urinary tract stones that cause renal obstruction, you take them to urologist, and then indwelling medical devices like uterostents, percutaneous nephrostomy tubes. So the management of infection may require exchange or removal of these devices. So you can remove these indwelling catheters to prevent continuous infection. Then other treatable factors should be addressed like optimal blood sugar control for the diabetic patients. For acute pyelonephritis, being considered as a complicated form of UTI, we treat it with fluoroquinolones, that is ciprofloxacin 500 milligrams per oral BD for 7 days, or you can give levofloxacin. The second line is Septrin. For hospitalized patients, the first line antibiotics are usually renal excreted fluoroquinolones such as cipro and levofloxacin, like we have said. Then for patients with more complicated pyelonephritis, other choices that can be given include ampicillin and gentamicin. So when I was practicing, we were treating UTI with this regimen, mostly in pregnant women, and yeah, it's good, it could work. Yeah, so we have all of these other medications that could be given in complicated cases of pyelonephritis. We have broad spectrum antibiotics like broad spectrum cephalosporins, azetrionam can be given. Then you have imipenem can also be given, but these medications are a little expensive in most of our settings, so we prefer to remain in the nitrofurantoins. Then you can move to ampicillins, gentamicin. Yes. All right. So we have looked at this slide before. For recurrency of UTI, ensure that you eliminate the factor that is causing the recurrent UTI. You make sure you educate them on the cause, how to prevent UTI. We have all of this, and also consultation from a specialist to help to ensure that to eradicate urinary tract infection. So let's look at the complications of UTI. Here we have pyelonephritis can occur. These are general complications. Perinephric abscess, urosepsis, then emphysematous pyelonephritis can occur. Then in male individuals, urethral strictures can occur due to continuous inflammation and healing with the scarring of the bladder. You can also have underurethra. You can also have inflammation of epididymis, that is epididymitis. Then you can also have inflammation of the prostate, that is prostatitis. Then you can also have inflammation of the testis, that is otitis. In pregnant women, this can increase the chance of preterm labor and delivery and its associated complications, of course, hypertension and then preeclampsia and its associated complication, plus chorioamnitis. All of this can occur due to urinary tract infection. So ensure that you prevent UTI by having these behavior modifications. Like one, increased fluid intake. This will increase the amount of urine that is being excreted, hence clearing the urinary tract system. Timely bladder voiding. Sure that you empty that bladder as soon as the body demands. Then postcoital voiding can be done, should be done. This will help to clear any organisms in case there has been inoculation. Then adequate genital hygiene. This should be taken seriously. Our mothers should be advised on adequate hygiene. And then clean intermittent catheterization. This is indicated for individuals with neurogenic bladder, and then it reduces the incidences of catheter-associated UTIs. What we mean by clean intermittent catheterization, instead of them having this catheter staying for long, they can only place it when necessary. Yes. Thank you for listening.